I want to welcome everybody to the meeting, let you know that the meeting is being recorded. I just saw another committee member join. So from my count, we have 6 members, which constitutes a quorum for the P&T Committee. Have a fair agenda to get through as always. Again, we're going to go through roll call and introductions, but for those that are guests on the meeting, please add your affiliation, the manufacturer you work for, or a CCO if that's the case, or if you're a public member, so that we can accurately reflect that in the minutes. And with that, we have the P&T Committee list up on the screen with their expiration dates and the role that they serve on the committee. For those that are listening in, you're following along on the screen. We'll be putting up slides throughout the day, but where you found the Zoom information to join the committee meeting, there's also the full P&T packet, and written testimony that was submitted for consideration, which have been shared with the committee, is also posted. So with that, we'll start off on the top of the order. And if you hold on one second, the first person on our list
Dr. Helm just joined. He needs to be a co-host. It looks like you made him a co-host.
That's what it takes, a few clicks and a few buttons for me to make him a co-host. So Mark, welcome. We were just getting going. You lead off the ranks for introductions. So if you're ready, we'll turn it over to you for introductions.
Okay, I guess I'm ready. I'm Mark Helm. I'm a pediatrician. Well, I live in Salem, but the pediatric practice is in Silverton. So I just drove in from there. So apologies for the late arrival. That's it.
Great, welcome. I haven't seen Russ join yet. Oh, hold on, we have a few more people. If we can pause for just one moment.
Good that I'm not the last to arrive.
Again, thanks for your patience. Just have a few more committee members. I need to hit a few buttons so that I can make them co-hosts so they have the ability to unmute themselves. For those that are just visiting or wishing to provide public comment, make sure you identify who you're with so that I can find you when it's your turn to provide public comment. And again, with that, Mark just did his introductions. Russ, we're over to you for introductions.
All right. Thank you. My name is Russ Huffman. I'm a psychiatric nurse practitioner, and I'm with Salem Health.
Welcome. I haven't seen Jim Rickards able to join us today. So Kathy, you were the early bird today. We'll turn it over to you.
Kathy Zaring, pharmacy manager at Salud Medical Center, pharmacist.
Thank you, Kathy. Pat?
Pat DiMartino. I'm a pediatrician and hem-onc faculty at OHSU in Portland.
Welcome, Pat. And Kat?
Hi, this is Kat Livingston. I'm the medical director of HealthShare and practicing family physician.
Welcome, Kat. Stacy is our chair, Stacy Ramirez.
Hi, everybody. I'm Stacy Ramirez. I am with the OSU College of Pharmacy and also the Community Health Centers of Benton and Lynn counties.
Great. Thank you, Stacy. Tim, I saw you join as well. Welcome.
Yes, this is Tim Langford. I'm pharmacy director with the Klamath Tribes in Klamath County, Oregon.
Great. Welcome, Tim. Karen will be joining us, but she, I think, is going to be a little delayed before she's able to join. So Robin, we'll turn it over to you.
Hi, good afternoon. Robin Moody. I'm a public member of the committee.
Welcome, Robin. And we will update your affiliation. And Bill, last but not least.
Yes, I'm Bill Origer, family medicine. I am on the faculty of the family medicine residency at Samaritan in Corvallis.
Welcome. We also have quite a few staff members, both with the OHA and with some of the contractors. So I'll turn it over, Jennifer, if you're able to join. She might not yet. So this is Roger Citron. I am the director of the Drug Use Research and Management Program, and we provide the clinical support to the OHA for the pharmacy program and to run this P&T committee.
I'm Trevor Douglas. I am the OHA Pharmacy Policy and Program Director. Happy to be here. Thank you all for showing up.
Hi, I'm Dave Engen, clinical pharmacist with the OSU DURM team.
I'm Sarah Fletcher. I'm a P&T clinical co-coordinator with the DURM team.
Hello, I'm Andrew Gibler. I'm the Clinical Pharmacy Policy and Programs Manager for OHA and pharmacist on the DURM team.
I'm Kyle Hamilton. I'm the Pharmacy Drug Coordinator here at OHA.
And I don't believe Dean was able to join us, so Megan will turn it over to you.
Hello, I'm Megan Herring. I'm clinical pharmacist at the College of Pharmacy.
Hi, I'm Deanna Moretz. I'm one of the pharmacists that works with the Drug Use Research Management team at OSU College of Pharmacy.
And I did not see Amanda join yet. I don't know if she'll be able to join us, so turn it over to Kathy Centena.
Thanks, Roger. I'm Kathy Centena, and I'm a clinical pharmacist as well with the OSU DURM team.
Hi, my name is Sarah Sherwood. I am the PNT clinical coordinator along with Star Fletcher for the DURM group.
Hi, I'm Lance Starkweather. I'm pharmacy manager for Gainwell Technologies.
I'm Dee Weston, Deborah Weston, go by Dee, pharmacy program policy advisor focusing mainly on Medicaid.
And I'm Brandon, excuse me, I'm Brandon Wells, pharmacy program analyst for Oregon Health Authority.
Fantastic. Welcome, everybody. Again, fair agenda to go through. Next is the approval of the agenda. At this point, we don't have any additions or change of order, so we'll continue on as planned at this point. Next is conflict of interest declaration. All staff, all P&T committee members, and anybody wishing to provide public comment are required to submit a conflict of interest declaration. It's incredibly important that the OHA is aware of, and the committee is aware of any conflicts when they're entertaining testimony. Those conflicts of interest are declared annually, and any changes are expected to be reported to the OHA. So at this point, we just give a small opportunity to see if any of the committee members have any conflicts they need to declare that haven't been done so previously, or any topics for which they need to recuse themselves. All right, hearing none, we have approval of the minutes. Those can be found on page 5 in the packet that's posted. And I've sent those out to the committee in advance, so they had a chance to review as they need to approve those. Does the committee have any edits that are needed for those the minutes? And if not, we'll need a motion to approve.
Motion to approve.
This is Russ, second.
All those in favor?
Aye.
Aye.
Opposed? Thank you.
And just before we turn it over to Trevor for the department update, Trevor will be standing in. We had Andrew on here. He'll be doing it in the future, but it'll be Trevor's opportunity today. Russ, I appreciated you introducing yourself when you just made the second. When the opportunity arises, if you have questions today, committee, it's useful. Sometimes you have your camera operating and we can see who you are, but it's also beneficial to those listening in if you can add who is speaking just for clarity. So if possible, please consider that. Thank you. And with that, we'll pull up some slides for Trevor and do the department update.
Before we do that, I'd just like to go back to Dr. Helm. He looks like he has a question.
I just wanted to abstain from the approval of the meeting minutes since I was not there.
Thank you, Dr. Helm.
Sorry about that. I forgot to ask if anybody wanted to abstain.
Thank you.
All right. Well, I'm, as you all know, Trevor Douglas, and happy to be able to stand in for Andrew today. Andrew's been exceptionally busy supporting the new COVID EAU proceedings and helping and assisting the senior health advisors at OHA. So really appreciate his work on that front, and I'm happy to do this update on his behalf. So really quick, I'm just going to hit on about 4 or 5 topics, and the most important is the last item on the agenda for the update. I'm not going to read through them. You can all read. Next slide, please. Thank you. We are busy preparing for legislative session. Luckily, it is a short session, and we also do not expect to see any huge groundbreaking policy shifts in the pharmacy space. That said, those are the famous last words. Now we'll see lots, right? So hopefully by next meeting in February, we'll be able to kind of know what the landscape looks like for the short session, and we can relay any legislative ongoing legislative work that relates to your work. Next slide, please. This should all be familiar to you. I just wanted to provide clarity as to which staff works directly with me and which staff has a slightly different reporting structure. And also highlight the fact that Dr. Harganani is now working directly for Patrick Allen, the director of OHA, as the chief medical officer. And I am now reporting to the interim director of the Office of Delivery System Innovation, Krista Mars. And under the pharmacy policy and programs section, we have Dee, who you heard from, Andrew, Amanda, who's unable to be here today, and of course, the wonderful Jennifer Bowen, who keeps us all organized. In addition, we have our great friends from the Health Systems Division, Brandon Wells and Kyle Hamilton, who work in concert with us and us with them. Just wanted to make sure you had that lay of the land down. Next slide, please. Wanted to just make sure everybody had their recruitment hats on for a moment. And this includes even members of the public that might be listening to me drone on about this, but I really think it's important and critical for even you folks to reach out to contacts that you have inside of Oregon, where you could let them know that there's opportunities to volunteer and be part of making sure Oregon eliminates health inequities and health disparities through participating in groups like the Mental Health Clinical Advisory Group, and this one that you are all a member of and also participating in. So currently there's an opening for a CCO representative on the Mental Health Clinical Advisory Group, an actively practicing community psychiatrist, 2 actively practicing clinical psychologists, and then there's also an opportunity to serve on that committee for the federally recognized tribes, and that seat will need to be facilitated and filled through our director's office and our tribal director to ensure that that position is indeed filled by a person who is representing those interests. Next slide, please. There are still openings on the PNT Committee as well. For those of you that are actively practicing physicians in Oregon in the public right now that wish to be considered, please submit your application today. Everybody else that knows a physician actively practicing within the state of Oregon, it's your job today to reach out and share the great news that they have an opportunity to join this wonderful committee and be considered for appointment. Hopefully I made that sound like a wonderful thing. Next slide, please. So that brings me to thanking a number of folks. But I want to first of all just let everybody know that there's a few people that have terms expiring this year. Dr. Helm, Dr. Huffman, Dr. Rickards, and also the early bird, Kathy Zering. So I really want to just very much thank everybody for their service, but also just note that as these terms have come to an end, that it's just a special time to recognize and honor that service of these individuals. And fortunately, both Russ and Mark have graciously offered to be reconsidered for reappointment. I believe Russ has his reappointment, and we are working on Mark's. And then just want to make sure that everybody has the opportunity to add their own gratitude for those who did not wish to be considered for a reappointment, but have definitely contributed greatly. Next slide, please. Which leads me to talk a little bit about Dr. Rickards. So Dr. Rickards has an extensive background in Oregon. And I know some of you will recognize that he was also the chief medical officer for the Oregon Health Authority from 2015 to 2017. And perhaps one of the better decisions that he made during his time was to hire me as the pharmacy director. All joking aside, Dr. Rickards has been exceptionally helpful over the years on different fronts, and just really appreciate his participation on our committee, and then also his mentorship to me personally over the years, and his willingness to volunteer in this appointment. He'll be missed, and I want to thank him personally, and I feel bad that he's not actually here to hear me highlight his most important decision. But anyways, there you have it. Next slide, please. Next is Kathy Zering. Well, I think there's no better word to describe Kathy as just a pillar. You've always been steady and reliable as a committee member. You've served from the inception of the P&T Committee in 2011. And without exception, Kathy is always prepared. She's clearly read everything and contributes very saliently to the meetings. Just your leadership and presence is just going to be very, very missed. And I just want to talk a little bit about Kathy. She has an impressive background. In addition to currently being the director of pharmacy, Services at Salud Medical Center, which is owned by Yakima Valley Farm Workers, Kathy also has served as I guess it's the site coordinator for all of the preceptor and student experience. And we're fortunate oftentimes to have interns over the years witness our P&T proceedings, and just really those students are so lucky to have Kathy's mentorship. Just an outstanding person, professional, and the perspective that you bring also, Kathy, having served in the public health service, in the Indian Health Service, and spending 23 years there is just hugely important and brings a valuable perspective. In addition to her work in the Salud Medical Center, Kathy has also been recognized by her peers. And in 2016 and 17, she was given the Oregon State College of Pharmacy Co-Preceptor of the Year award. And that just highlights, I think, Kathy's commitment, not just to her profession, but to the individuals that will be standing on her shoulders, most certainly in the future. So Kathy, I'm going to miss you. I'll miss your smile, and I can't thank you enough for your commitment, and you set the standard as far as I'm concerned, as far as being prepared and just being so steady in your place. So thank you very much.
Thank you so much, Trevor. I can't believe you found all that information about me. But it was really, really great volunteering on this committee. It was a highlight for me to attend and prepare for the meetings. I enjoyed working with all the committee members and appreciated their insight and input. And the Durham committee has been, amazing for all the preparation that required to hold the meetings. And I felt like I've grown as a pharmacist, and I understand the decisions and input that takes place to serve our patient population. So I had made a decision about 3 years ago that I was going to retire this year. So that's the reason why I'm not continuing. So I have some more free time. So I'm planning on retiring. My last day of work will be February 4th. That'll be 38 years of being an active pharmacist. So this is it's going to be was one of the great highlights of being on this committee, and I'll definitely miss everyone.
We will absolutely miss you, Kathy. You were one of the inaugural members. You're just so diligent with the information, bring a valuable perspective. You will be greatly missed. And I'll give you about 3 years before I see if you're interested in being a public member.
I know. That's fine. That sounds like something I would be interested in. Thanks for.
And if you're bored in retirement, don't hesitate to give me a call. I can always put you to work.
Okay. Thank you. I'm going to miss everyone. I wish I could be there in person to see everybody, but it's been great work with everybody.
Likewise. Thank you, Kathy. Again, thank you very much on behalf of the OHA, and I think the entire team just feels the same way I do. So thank you. All right, that's it. Thank you. Back to you, Roger and Stacy.
Great. All right, continuing on in the agenda, for those following along on the packet, we're on page 10. The next section is our consent agenda. So we include our quarterly utilization reports. We also include scans. Generally, these mean that there's no new clinical information that warrants any recommended changes. We're just going to look at those in executive session for pricing. New oncology agents, new orphan drug policy agents are also included in those criteria. So we don't have anybody wishing to provide public comment. And unless the committee wishes to take any of those topics off to discuss them or ask questions, we need a motion to approve the recommendations.
Sorry. Now I'm all messed up. All those in favor, I got all the ayes. Any noes or nays? And abstain. All right, thank you guys. Sorry about that.
Good job. No, great job.
I have to remember to say abstain next time.
The P&T Committee also serves as the federally mandated drug use review board. So when pharmacy is elected to be as a benefit for a Medicaid agency, it requires that DUR activities are held quarterly. So the P&T Committee serves as the DUR board, and we focus at least one meeting each quarter on DUR activities. So we're going to start off with prospective DUR and turn it over to Lance Starkweather, who is the program manager for Gainwell Technologies.
All right, thank you, Roger. So for the third quarter of 2021, there was a total of 10 different DUR alerts. We didn't have any drug allergy interaction alerts, of which these total up to 115,000 alerts total for the quarter. The two primary alerts that are set to have the claims denied are the early refills and the pregnancy interaction category. The number of alerts that had the highest were the early refills, ingredient duplication, and also therapeutic duplication. When we look at the early refills, we had almost 76,000 alerts total, of which a little over 13,000 was overridden. So that had to be a manual override in order to get the claim to pay, equating to 17.3% of the overrides. For the pregnancy drug interaction, we had a total of 14 alerts for the quarter, 13 were overridden, so 92.9%. Next slide, please. So when we look at the early refills by drug, these are the primary mental health drugs that are being overridden. The highest numbers of the alerts for drug-wise would be the lamotrigine, quetiapine, and buspirone. In terms of the drug with the highest number of override, it's actually the Suboxone, so buprenorphine, naloxone. 31 claims total, and 9 were overridden to 29%. The other category of drugs that actually had a high number of alerts is actually the benzodiazepines, so lorazepam, alprazolam, and diazepam. Those all equate to about 20% of the overrides. Next slide, please. So in terms of reason for the early refill override, we had a total of over 10,000 overrides for the quarter. Majority of them had to do with medically necessary. So the drug was determined medically necessary for the patient. The next highest number is due to a change in therapy, so a dose change or just a change in a different drug. And that is primarily it. Next slide. So the ProDUR alert cost savings. So these are the alerts that popped up and the prescriptions did not get dispensed. We had 2 for July. That equal over 48,000 in cost savings. For August, we had a total of 5 different alerts, totaling 7,800 in savings. And then for this month of September, we had 7 over different alerts, and that is about 12,000. So for the third quarter, it's 25,1752 total in cost savings for the ProDUR alert. That is all. Any questions?
Thank you, Lan. Any questions for Lan on the prospective DUR? All right, after ProDUR, we have retrospective or RetroDUR. I apologize, I've included the previous report in the packet. I've asked to that be updated, but what we have up on the screen is actually the 4th quarter report, so the most recent information that Dave will be going through. I also sent this to committee a little bit in advance, but if the numbers look a little different, what somebody might have seen in the packet to what's on the screen, that's the explanation. So with that, Dave, I'll turn it over to you and direct the audience to what hopefully is now page 49 in an updated packet.
Okay, thank you. Actually, what I see on the screen there, it's not the beginning of the report, so but I can jump ahead. Let's see. So usually we start off with change forms, but I'll go ahead and start with the safety net. So hold on a second here. Yeah, so these are PA denials, and there's been no subsequent PA requested or possibly a dangerous drug combination. So a little bit of a drop off in those identified, so that's actually a good thing. You can also see there's been an uptick in the number of discontinuations at 42, so that's good as well. Also a reduction in the average number of sedative drugs dispensed within 90 days. So all things trending well there. We've got antipsychotic dose consolidation denied claims, and these are denied fee-for-service antipsychotic claims within the past 14 days. And you can see the majority of those patients end up with a paid antipsychotic claim. So all those, you can see that those numbers are trending well. Also, we've got the ICS LABA, and so we have not a whole lot there, and that's actually a good thing as well. These are patients that are missing respiratory controller meds after a claims denial, so we message on those. And yeah, so let's go ahead and go to the next page, and I'll try to catch up. So you've got, okay. And this initiative, TCAs in kids, you can see the number of patients identified without a new claim, and 2/3 of the patients end up with a claim after a notification. So these are kids that, or these are prescribers of TCAs in kids that are, the claim is denied, and this is kind of a follow-up. So more or less a safety net. So that's a good thing. And if we go ahead and go to the next page, so you've got change forms. Let me get there. Yeah, so I just wonder, we are looking at quarter 4, so snapshot in time. So the numbers are constantly changing. Just be aware of that. I mentioned that before. For venlafaxine, about a third of the prescribers that are notified are making a switch. So that's good. Not a huge savings, but you know, definitely less than when we started. But it could be a result of pricing changes, but also it is cumulative, so that number will get bigger over time. So the skip down to venlafaxine tabs to caps, so we're still finding an opportunity there with formulation switch. About half the prescribers still be they appear to be switching after being contacted. So once again, a good thing. Next page, cost savings. Yeah, this is Retrospective dose consolidation. Not a lot of action with those, but most of those, that messaging is going on at point of sale, and that's not captured here, so it's not surprising. But yeah, so we've got, we'll have some more opportunities that we may share with you the next meeting of potential dose consolidation opportunities. If you go on to the next, yeah, this is our expert consultation referrals for long-term antipsychotic use in kids. This is there's an initial identification, and but those that have already have a PA written or PA authorized or it's written for short-term use, those are disregarded. So we're down to we had 3 that were identified that rose to the level of kind of a red flag, so to speak. Maybe no evidence of metabolic monitoring or you know, more than 6 months therapy kind of thing. So 3 got referred, and 2 still continued after the consult. So that's up and running and going well. So the next, and so this is non-adherence to antipsychotics in people with schizophrenia. And once again, this messaging goes out to prescribers if there's a gap in medication refills after 14 days. And so it appears roughly half the patients ended up with a claim in the next 90 days after the prescriber was notified. So we feel it's doing a helpful thing and good work there. So go ahead and the next slide or the next page. And yeah, so these are profile reviews. The first 4 categories actually, they're for foster kids. We generate profiles for the OHA, and that's passed along to DHS, and they get referred to OPAL-K if needed. If you about halfway down as high-risk patients, we review those high-risk profiles, and when appropriate, we make clinical recommendations that are sent to the prescriber, and they're based on recent guidelines, best practices. You can see the numbers there. If you look down at lock-in, for example, of another initiative that we have, there's a big drop-off in patients that were identified for lock-in using the same criteria that we've had. So we think that, you know, the PAs on short-acting, long-acting opioids are likely helping keep these numbers in check. So trending in the right direction as well. And then the last one, polypharmacy, we review those folks that have 15 drug claims in 6 months and look for opportunities to deprescribe or encourage deprescribing or improve safety. So I think, do we have any? So yeah, I'm trying to, we got a little out of sync there. We went through that next one, so yeah, I think we're good. Any questions or anything? So happy to entertain those.
Thanks, Dave. Any questions for Dave? Again, this reflects the work that you recommend, the OHA, that we implement. our DUR initiatives, and we try to track that. So questions for Dave? Okay. One additional component of drug use review is education. And one of the ways that we achieve that is through our newsletters. And so direct your attention in our packet to pages 56 and 60 for some of our more recent newsletters. And we'll turn it over to our editor, Kathy Centena.
Thanks, Roger. So yeah, today we'll just be recapping two newsletters that were published in April and May. The first was a COVID-19 vaccine update. This newsletter reviewed the evidence for the authorization of the 3 COVID vaccines, including a discussion on comparative efficacy, use in special populations, and efficacy against variants. The newsletter also touches on ways to decrease vaccine hesitancy, as well as inequities in vaccination rates. And then the second newsletter, starting on page 60 there, is on deprescribing techniques. And this newsletter discusses targeting appropriate medications that may be candidates for discontinuation, strategies for deprescribing drugs that are prone to withdrawal, and then tools to assist in that process. We continue to send the newsletters out to the committee as drafts, and really appreciate your comments and suggestions on those. The next newsletter is going to be on treatments to treat and prevent COVID. And at this time, I'd like to solicit the committee for any newsletter topics that you think would be of value to our providers. You can always email those to us if you think of anything. And then just a reminder too, you can sign up on the website to receive the newsletters electronically if you don't already do so.
Great, thank you, Kathy. All right, we're right on schedule, so we'll turn to your attention to page 64 in the packet. We have the anakinumab prior authorization update. We'll turn it over to Megan Herring.
Thank you, Roger. So this is just a brief prior authorization update. Just a reminder, we reviewed this drug at the August P&T meeting. Evinacumab is a monoclonal antibody-like agent that is indicated as adjunct to other LDL lowering therapies for the treatment of adults and pediatric patients aged 12 years and older with homozygous familial hypercholesterolemia. It was approved based on one study that demonstrated a significant reduction in LDL compared to placebo at 24 weeks in patients with homozygous familial hypocholesterolemia on maximally tolerated lipid lower therapy. However, just a reminder, there's no data available on its effects on cardiovascular morbidity or cardiovascular mortality, and its safety and efficacy have not been determined or established in other types of hypercholesterolemia. So the committee asked to bring this back with some renewal criteria. The initial criteria basically just ensures that the patient has a diagnosis of homozygous familial hypocholesterolemia and is on maximally tolerated doses of a statin, ezetimibe, and a PCSK9 inhibitor. And so the renewal criteria was added for today. And this is basically looking for some kind of treatment effect from evinacumab. So we're asking for the most recent LDL cholesterol level, and then ensuring that the patient achieved either an LDL reduction to less than 70 or 30% decrease from baseline after adding evinacumab. And then number 3 is just, again, asking that the patient is adherent with other lipid-lowering therapies, including statin, ezetimibe, and PCSK9 inhibitor. The 30% decrease came from my kind of best estimate from what was seen in the clinical trial. So in the study, there was a mean difference in change in LDL compared to placebo of about 49%, and then in the confidence interval was between 65 to about 30%. So the 30% decrease is kind of a conservative estimate based on the mean difference from the study population. And with that, I will take any questions.
Hi, this is Kathy Zaring. Just on the renewal criteria, I thought maybe it would still be a good idea to ask those safety questions regarding childbearing I don't think it should be overlooked when we renew the medication.
Okay. Yeah, we can add those down in the renewal criteria as well. Thank you.
And we do have one representative from Regeneron that wished to provide public comment. It seems to be having some technical difficulties. Matthew, are you able to unmute yourself? I've made you a co-host.
I think you'll have to make him a co-host again.
Okay, he's logging out and logging back in repeatedly, so let me try to find him. We'll make this attempt again. Matthew, can you hear me? Matthew, PharmD with Regeneron, wished to provide public comment, but he's apparently having technical difficulties. Matthew, I see that you've unmuted yourself. Are you able to, can we hear you? Don't know what to say here with your technical difficulties. Everybody else can hear, you can hear me fine. I can hear the other presenters fine. We're not making substantive changes to the PA criteria, but I don't want you to lose your opportunity. Matthew, can you hear me?
He's putting stuff in the chat. I don't know if you. He said I can't hear the audio again, so I'm wondering if he's totally gone.
Yeah, he hasn't been able to hear it the whole time, and then he asked me for some captioning, so live transcription. Yeah, Matt, I'm sorry you don't have an opportunity. Looks like you've left the meeting again. Okay. Apologies that you're not able to provide your comments to the committee. Yeah, I guess you can submit some comments if you want in writing, or if you don't agree with the recommendations that are being made by the committee based upon what we're putting in front of them for these PA criteria changes, there's always an opportunity to make those concerns known to the OHA when the recommendations are presented to Director Allen. So unfortunately, we're going to continue to move on. Again, go back to the committee. Do you have any questions for the recommendations that Megan has presented?
And one thing that I just noticed is, since we're asking for a reduction in LDL, I should probably add for a baseline LDL in the initial approval criteria. So I will add that as well.
Okay, so the recommendation in front of the committee is to update the PA criteria to include the renewal criteria and the LDL, as Megan just mentioned. Do we have a motion to approve?
Hang on just one second. I actually have a question, because the discussion about the baseline level and the question about the % reduction. So is the baseline level for the evinacumab, is that baseline level after maximal therapy?
Yes, it would be
Okay.
like baseline just before adding the evinacumab therapy.
Okay, all right. I just wanted that clarified, because if you look at the baseline as in prior to treatment,
Yeah.
It doesn't make a lot of sense. So, okay.
So I guess I could, instead of baseline, I could word it like, recent LDL within some sort of recent.
Yeah, I think it's a question of like, with a recent LDL level after adequate, which probably like 6 weeks to 8 weeks, maybe longer, I don't know, use, consistent use of maximal therapy.
Okay. Yeah, I think usually it's recommended to check like 4 to 12 weeks after, so I can include that.
I think 4 weeks might be a bit aggressive, but that's, I defer to my adult colleagues, implying that I'm a child.
Do any of the adults in the room want to weigh in?
I think I agree with that, and you're not a child. I think the 4 weeks probably is, we may need to go out a little longer than that.
6, 8 weeks because we get monthly fills. What's the preference?
8 sounds good.
Yeah, I think 8 to 12 really.
Technically, I assume 12 weeks is what we would use to ever measure effectiveness.
So what you're saying basically is like 3 months on maximal therapy, and then if you're still not at your goal, then you think about adding adalimumab.
Yeah, I mean, that's clinically, that's how I would do it, where you make sure that they still need it after 3 months of treatment.
Right.
Yeah, I think that actually sounds completely reasonable. So it seems like 12 weeks maybe is the consensus.
Just to clarify, so we're talking about changing the renewal criteria number 2 to say, did they achieve the LDL reduction to less than 70 or a 30% decrease following at least 12 weeks of triple therapy of statin, ezetimibe, and a PCSK9?
I guess I was going to change in the approval criteria to ask for a baseline LDL after 12 weeks of maximally tolerated therapy. So basically, I get number 3, just clarify that they have to be on those treatments for at least 12 weeks and then have an LDL.
Right. There's also baked into this an expectation that they continue with triple therapy, correct?
Yeah, at the in the renewal criteria, it asks that they're still adherent to their statin, ezetimibe, and PCSK9.
Right. Who assesses adherence? Is that assessed at the by review of pharmacy dispensing, or is that assessed by the prescriber who really actually has no idea?
In terms of operationalizing the PA, I don't know exactly how that's done, Roger.
Yeah, Lan, are you able to speak to that? If you get a renewal request for this therapy and your team is reviewing it, when you go through this question, how would you adjudicate that question?
We typically do look at the drug profile, but some of them do not show unless they were all covered by fee for service. So that's the challenge there.
So you have the claims history, if possible, if the person is fee for service only, no TPL that maybe have paid everything, and they've had continued enrollment. And if not that, then you would take the provider's attestation or chart notes.
Yep.
So in a situation where you can't see that, why not ask the provider to actually secure from the pharmacy, whichever was doing the dispensing, whether it was covered through fee for service or not, secure the dispensing records?
The provider might not know where which pharmacy the member went to.
Yes, they would, because they send the prescriptions.
Well, they can write prescriptions and a member walks them to a pharmacy and they're not sure where they went.
Rarely happens. And
you know, if you're working with an EHR and e-prescribing, certainly you're right. It could be transferred and the provider isn't aware of that. Just there's challenges with what you're proposing.
I understand. You know, but I think that you know, when you're looking for evidence of adherence to therapy, the pharmacist is really the only one who knows.
Agreed. Again, we can work with Gainwell Technologies, and if they're not satisfied that they feel comfortable that they've achieved this, you know, 80% adherence, certainly we can ask them to deny and get additional information that we can review through a reconsideration process.
Well, and I think that would actually be appropriate. I think that if Gainwell doesn't have the dispensing history and can't certify that that's done, then that should go to a higher level review.
We can definitely take that under advisement as we collaborate and coordinate with Gainwell. Okay, so Megan, do you want to recap the amended changes that we're doing in addition to what you've presented here?
Sure. So amended changes are to clarify in the approval criteria to ask for a baseline LDL after at least 12 weeks of maximally tolerated triple therapy with statin, ezetimibe, and PCSK9 inhibitor, and then to add the questions about use in pregnancy and those risks into the renewal criteria as well.
Anything else to consider, or do we have a motion to approve as amended?
Motion to approve as amended.
Second, this is Helm.
Second.
All those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
Thank you. All right, continuing on, we'll direct your attention to page 67 in the posted packet. And we have a Spravato safety edit update, and we'll turn it over to Sarah Servant.
Thank you. So this update is for esketamine or Spravato, and we have a safety edit based on some of the clinical safety characteristics of the drug. Just as a reminder, it is indicated for treatment-resistant depression and for acute treatment in patients with depression and suicidal ideation. It's been previously evaluated by the P&T Committee, and we're bringing it back today to just clarify some changes in appropriate maintenance dose and use in patients with a history of substance use disorder. It is scheduled, a substance that's scheduled by the DEA and is associated with a REMS program to hopefully mitigate some of the potential safety concerns around substance use and potential abuse. In clinical trials, patients with substance use disorder were excluded from those trials. But one of the issues that we ran into when adjudicating PA criteria for this drug is that substance use covers a wide variety of different types of substance use and different severities of substance use. We'd previously included a question in the PA criteria asking whether the patient has a history of substance abuse, and if yes, to deny the request for the medication. When we talked about this with the folks at the Mental Health Clinical Advisory Group, they recommended that we simply take out that question just because of the difficulty and the variability in history for patients with a history of substance abuse. It's really difficult to evaluate all of those conditions and all of the different types of severity with a simple question. And so their recommendation was to take that question out and leave it up to the prescriber to assess risk factors associated with substance abuse with this drug. Like I mentioned, it does have some potential side effects and is associated with a REMS program, and so it has to be administered in a provider's office in order to mitigate some of those concerns.
Have we had any
Some of the other updates to this criteria are mostly clerical. We're clarifying the language in question number 6 to specify that treatment-resistant depression is defined as 2 separate antidepressant trials of at least 6 weeks at target doses rather than 2 antidepressants used at once. One comment when we brought this to the Mental Health Clinical Advisory Group was that this was a pretty low bar for treatment-resistant depression. So there was some discussion around that, but they didn't have any specific language to add to this question, or any suggestions to add. We're also clarifying language in question number 8 to assess whether it's current or history of for all of these various conditions for which there might be contraindications to the drug. And then, like I mentioned, clarifying the appropriate maintenance dose in the renewal criteria, because esketamine after 4 weeks is only recommended once weekly or once every other week rather than twice weekly. So I'd be happy to take questions on any of these changes.
Bill, did you have a question?
How many claims have we had for this?
I don't know the exact number, but it is, because it's a mental health drug, it is carved out. So we are responsible for the entire
million lives.
population, yeah, on Medicaid if it goes through as a pharmacy claim, for which, so we do have quite a bit of use.
Okay.
Pat here with one random question on approval criteria number 8 with the hypertension. It looks like per the label, hypertension isn't an absolute contraindication. So I don't know if Russ, you would know better than me, but that would be the one point on number 8 that was maybe looked like a little bit of an overstep compared to the label.
Does it matter if it's uncontrolled or controlled? I guess. Does that make? Yeah.
Yeah. And looking at like the label, I think it just said like assess blood pressure prior to dosing and keep an eye on it. But yeah, I don't feel strongly. Just curious.
Raising the blood pressure is a known side effect of the medication. So maybe that's why they chose the 140/90. Would it be more appropriate to use more of a hypertensive urgency or something like that? History of?
Yeah, I just would hate for like a denial to occur for like a soft call when like maybe the prescriber is best able, if they're aware of the blood pressure issue, to sort of ascertain the risk benefit profile.
The language that Pat was reading there suggests that it's assessed at the time of administration as well.
Perhaps we do have public comment from a representative from Janssen. Perhaps they can address that in their comments. I don't know if they have canned comments or if they can go off script. Do you wish to hear that public comment and then we can come back to this discussion?
That sounds great.
Okay. With that, Sophia, are you able to unmute yourself?
Hi there.
Great. We can hear you loud and clear. I give you 3 minutes, up to 3 minutes to address the committee. And with that, the floor is yours.
Perfect. Thanks so much, Roger. Good afternoon, everybody. My name is Sophia Yoon, and I'm a pharmacist with Janssen Scientific Affairs Value and Evidence team. I'm here to just address any questions that you had regarding Spravato. A lot of the speaking points that I had ready for the committee today, Dr. Server did an amazing job highlighting all the things. It is a Schedule III controlled substance under the U.S. Controlled Substance Act, and it hasn't been studied with patients that have comorbid substance use disorder, as noted that in your packet materials. The only thing I really wanted to highlight that is Spravato does have that risk evaluation and mitigation strategy, or REMS, and the product is really intended for patient administration under the direct observation of a healthcare provider, and patients are required to be monitored by a healthcare provider after the administration, and it's really never meant to be dispensed directly to a patient's for home use. And the other piece regarding blood pressure, it is not a contraindication that is within the label. The recommendation within the prescribing information is to assess the blood pressure prior to as well as after administration, just to monitor.
So if they have uncontrolled hypertension, no problems, they should use it?
I'd like to follow up with a written submission if that is appropriate per the committee.
Well, we're going to be making a vote on this right now, so I was just trying to get your input on that. But does the committee have any other questions for Sophia?
Well, yeah, I guess the concern that I would have is a situation if you if we said, well, if your blood pressure is elevated, we're going to check your blood pressure before, but we're going to go ahead and give it to you, and then if you have an adverse event, that looks really bad because of the REMS. So I would think that actually Janssen would be interested in making sure that patients who have uncontrolled hypertension are probably not going to receive the medication, but what do I know?
Well, and to reiterate our process, this is the criteria that Land's team at Gainwell Technologies uses to adjudicate a claim. And so if someone had, as written here, current uncontrolled hypertension, right, that claim could be denied, but then it would go to that higher level, the PA reconsideration that could come to us with clarification, justification, or reason why they think that's appropriate. And so it would still have a pathway to be approved with treated hypertension. Does that suffice?
That makes good sense to me, but I'm only one vote.
Okay.
Yeah. I'm Pat here. Mark, that sounds reasonable.
Okay. Any other questions for Sarah, or do we hear a motion?
So moved. This is Robin.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
Great. Okay, keeping it in Sarah's court, we have the HIV pre-exposure prophylaxis DUE, drug use evaluation. If you're following along in the packet, it's page 71.
Thank you. So today I'm going to be presenting a short drug use evaluation on the pre-exposure prophylaxis and patients who might be at risk for HIV transmission. And so current guidelines from the U.S. Preventative Services Task Force and the CDC recommend pre-exposure prophylaxis for individuals who might be at high risk for HIV transmission. And they do have some current criteria that define who might be at higher risk for HIV transmission. And so the goal of this DUE was to really look at whether we could identify patients who might be at high risk and see if they were receiving pre-exposure prophylaxis for HIV. So the methods that we used for this DUE were really just looking at a snapshot in time for Medicaid patients with risk factors for HIV transmission or who had HIV testing. We included fee-for-service patients who are over 10 years of age if they were enrolled in Medicaid in October of 2021 and had either an HIV test in the past 6 months or medical claims which might indicate a potential risk for HIV transmission. And so those diagnoses that we included codes for sexually transmitted infections, high-risk sexual behavior. There are specific ICD-10 codes with that descriptor, or potential viral exposure. And some of the limitations that I wanted to just bring up before we go into the results for this. The results really only reflect individuals we're able to identify based on these ICD-10 codes. Many of these codes could be or are stigmatized, which might influence how prescribers use them for billing. And then the population that we identified is likely influenced by the ICD-10 codes which are available. So for example, in patients with substance use disorders, ICD-10 codes don't break out type of substance use by route of administration. So we're able to identify injection drug users who might be at higher risk compared to people with substance abuse that abuse drugs orally. So just looking a little bit at the results that we found, we identified almost 1,000 patients that had HIV testing or risk factors, which might indicate high risk for HIV transmission within the past 6 months. The majority of these patients were identified based on an HIV test. However, about 20% had a diagnosis of indicating a sexually transmitted infection in the past 6 months. About 5% had high-risk sexual behavior in the past 6 months, one of those diagnosis codes, and about 10% had potential viral exposure. And most of these patients were identified based on only one of these factors, but about 10% had more than one of these factors. Of note, very few white patients were identified, and more than half of patients with HIV testing or risk factors for HIV transmission were American Indian or Alaskan Natives. About 24% of patients included in the analysis identified as other non-white racial groups. When we looked at the proportion of these patients that had fee-for-service pharmacy claims for pre-exposure prophylaxis, there were very few patients, less than 1%, who had a claim for PrEP. And again, just some of the data limitations. So this reflects individuals that we were able to identify that might be at risk for HIV transmission based on medical claims. It's certainly not the entire population of patients in Medicaid. Billed diagnosis might not accurately reflect actual diagnosis in patients' charts. And because this analysis only evaluates claims data, many of the clinical considerations and risk-benefit evaluation that's going into some of the individual patient-level decisions on whether an individual is eligible for PrEP or wants to take PrEP are captured with this analysis. However, despite this, there is a fairly significant portion of patients that might be eligible for PrEP based on medical claims data. And so the recommendation here is to look into opportunities to develop educational Retrospective programs to improve provider knowledge of PrEP for high-risk patients, such as those with a recent STI or with potential viral exposure. I'd be happy to take questions.
Sarah, does so the U.S. Preventive Task Force Service is really focused on injectable drug users. I really question whether or not it actually matters the route that you're using, the substance, the consciousness altering substances, particularly in terms of like risk factors for sexual activity. I just didn't know if you had a comment on that, and if we should consider that a qualifying diagnosis is a substance use disorder, regardless of route of administration.
Yeah, it's a good question. I know, like we were discussing earlier, there's all sorts of different types of substance use, and I know some of them are I think probably do have higher risk. You know, you get into cannabis use disorder. Do you include those patients? Maybe, maybe not. The U.S. Preventive Service Task Force does specify not only people who inject drugs, but also people who inject drugs and use shared needles or shared equipment as higher risk patients.
Yeah, but I would also think, someone who is intentionally using ecstasy or, poppers or other kinds of substance abuse kinds of things that can be in certain circumstances, that those folks may also be at higher risks as well. So I guess that's my question.
Yeah, I think it's a fair question. I don't know that I have the answer.
Other questions for Sarah? We do have 2 people that have signed up to provide public comment.
Can you hear me?
Yes, can hear you, Russ.
Okay. Sorry. For some reason, my Zoom will not listen to my laptop mic, so I had to get my headset. Anyway, I mean, there is data that, I mean, even, alcohol use increases risk of contracting HIV, and there's no research that I'm aware of that on cannabis use, but I think Mark makes a good point that anything that alters thinking and would increase your risk. I mean, it makes people more likely to do any sort of to alters their perception of risk, and so they're more likely to take sexual risks. But
so as we're reaching out to prescribers, we could certainly look at those populations as people that we include when we're or consider including when we're identifying prescribers to reach out to.
I have two thoughts right now. So the first is this might actually be a really great topic for a newsletter, just for overall kind of upskilling people in terms of evidence about who should be treated with PrEP. So that's one idea. And then the second is just looking at the demographics and thinking about a retro DUR program, I would just want to be really cautious that there may be a lot of people who are totally appropriately tested for HIV because their clinic is doing really fantastic screening programs and just getting everybody tested routinely, and they're not actually high risk. So I would just really make sure if we're developing criteria around who to reach out to, that we're really trying to not have it go out to people who are just doing really good screening rather than have it actually be targeted towards people who are at high risk.
Well, and that's this is Kathy Centena. We actually have a newsletter that's coming out in the next couple of weeks on this. So that's I'm glad that you think that's a good topic.
Yay!
I think just letting people know that it is covered by the Oregon Health Plan is the main information.
Great. We do again have two people that provide public comment. First, we have Jonathan Froxwag with the Cascade Health Cascade AIDS Project. Jonathan, are you able to unmute yourself?
I am.
All right. I'll put the scary screen up here with the counter. Again, the floor is yours for up to 3 minutes.
Okay. I have brief prepared testimony, but first I just wanted to quickly address the discussion that was just happening. And I think that's exactly right, that other substance use could be indicators for HIV risk. And I'd really encourage the DERM folks to coordinate with the HIV section of OHA on that. Personally, I'm not an expert, but I've never heard of any link between HIV risk and ecstasy use or cannabis use. The most common substance use that we hear about in connection with the HIV epidemic is meth use, which is unfortunately pretty higher than average among gay, bisexual, and other men who have sex with men, which, as you know, is a high-risk group. So just providing some additional information there. I'm really, again, my name is Jonathan Froxwig. I'm the Public Policy Manager for Cascade AIDS Project, or CAP. We're the oldest and largest HIV services provider in Oregon. I wanted to testify today just to commend the OSU College of Pharmacy and OHA for undertaking this evaluation. And I'm also testifying to express CAP's strong support for the recommendation that an educational retrospective drug use review program be developed to improve provider knowledge of PrEP. This evaluation confirms what national data show and CAP's PrEP navigators see on the ground, which is that not nearly enough people who are at risk of HIV are on PrEP. And there are many reasons for this, including racial disparities in access to healthcare and lack of LGBTQ+ cultural competence among healthcare providers. But certainly, I think inadequate provider knowledge of PrEP contributes significantly to low PrEP uptake. The US Preventative Services Task Force's A rating of PrEP in 2019, along with the arrival of generic PrEP on the market, have created the conditions for finally treating this safe, simple medication as the low barrier HIV treatment, or excuse me, HIV prevention tool that it should be. And improving tracking of PrEP prescription data and educating providers will help get PrEP into the hands of the people who need it most. So we hope you'll support this proposed initiative. Thank you for your time and consideration.
Thank you, Jonathan. Any questions for Jonathan? Appreciate it. We also have Stuart Abrakta, a familiar voice, but usually he's talking about DAAs and Hep C. So a little departure, and he's going to talk about HIV and PrEP. So again, Stuart Abrakta with Gilead. Are you able to unmute yourself?
Can you hear me, Roger?
I can hear you and see that tie. Nice work.
Oh, okay. I wasn't sure if my video was working too. So if before you start my time, if I could ask, I'd like to make a couple comments on the discussion you had, maybe to add some context. I agree with many of the things that were said and commend you for the review as well. I think the thing that you're differentiating and getting confused about is the fact that IV drug use in and of itself is a risk, but the substance abuse is the risk too. Oh, you started my time, Roger. I was just helping you with questions. Can you go back?
I thought you were providing comments.
Oh, I wanted to give you some insight before my comments. I was trying to help with your discussion. The other thing is other thing that, you. Okay, well, I'll say it at the end. So I'd like to talk about Descovy today, just to say thank you for having it on your PDL, and I'd just like to highlight a few things as far as its potential advantages in some patients for HIV prevention.
The Liberty.
Descovy is a combination of emtricitabine and tenofovir alafenamide that was first approved for the treatment of HIV in 2016, but also for prevention in 2019. It is approved for adults and adolescents weighing 35 kilograms, but it does exclude the vaginal intercourse population because it wasn't studied in that population yet, but we are studying it now. Descovy for PrEP was studied in the DISCOVER trial in a double-blind randomized active control trial with a comparator of Truvada. This is the largest HIV prevention trial and of over 5,000 patient participants. This was an event-driven non-inferiority trial which did meet its primary endpoint, but Descovy did demonstrate an almost 50% lower infection rate than Truvada with similar adherence and patient characteristics. Some experts attribute that to a difference in the pharmacokinetics of Descovy. In both study arms, essentially all patients failed because of lack of adherence based on drug levels that were taken. So this would indicate that's the primary reason. Ending with safety. Renal safety and bone safety differences with Descovy and have been demonstrated in treatment trials in multiple real-world and clinical trials. This was consistent with what we saw in the DISCOVER trial. There's little or no negative impact on renal clinical markers with Descovy as compared to Truvada. And most importantly, Descovy had no cases of PRT or Fanconi's, the most severe adverse effect from Truvada. And there was one case in the Truvada arm. For bone health, in the DISCOVER trial, there were significant increases in BMD for the Descovy arm, and there were decreases in the Truvada arm. What's most important about this, in the population that was less than 25, which was a significant group of patients in this population, they saw even a higher magnitude of decrease in bone mineral density where they should be gaining more bone to reach their lifelong maximal bone density. Previous Truvada prevention studies have also shown this reduction in bone mineral density trajectory. And what's most concerning is the lack of resolution or return to baseline after Truvada is discontinued, impacting potentially lifelong fracture risk. So in summary, there are safety differences that are demonstrated in these trials, both renal and bone, and current monitoring techniques in clinical practice don't effectively evaluate these. So thank you for having it available, and I'd like you to continue to make it available so that patients and providers can choose. So thank you for your comments. And I know my time's up, but I wanted to make one recommendation to you about the idea of the HIV testing. I agree that it could be that screening is being done very well. But if you put a timeline and you have multiple tests within a certain time, that would weed out a lot of that, because multiple tests would suggest risk. So thank you. Did I get cut off?
Now I'm on mute. Thank you, Stuart.
Okay. I'm like, I was silent. Okay.
You wanted extra time. I'm just going to leave you there hanging just in silence. Any questions for Stuart? All right.
Thank you very much. Good to see everyone, at least virtually.
All right, we'll turn it back over to Sarah. Recap the recommendations from the committee and see if there's any more questions.
Yeah, so thanks for the good discussion. So the recommendations would be to develop educational literature programs to improve provider knowledge of PrEP for high-risk patients. And we can certainly consider including other substance use disorders, within that population as patients who might have potential risk, combining that with some of these other diagnoses to identify the most appropriate patients to message on.
Okay, do we have any more recommendations or thoughts for us to consider, or do we have a motion to develop the educational retro DUR initiative?
Motion to develop the educational retro DUR initiative.
Second.
Lots of seconds. All those in.
Aye.
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 Anyone opposed? Abstain? Thank you all.
All right, well, we're staying on schedule today, so we're going to move on to page 79 if you're following along in the packet. We have the glucagon class update and new drug evaluation. I'll turn it over to Kathy Centena.
Great, thank you. Yeah, so today we'll be talking about the glucagon class. This is in response to just updating this class with any new literature, as well as a newly approved product for this class. The new drug evaluation will be on dasiglucagon, which is a new anti-hypoglycemic agent approved for the treatment of severe hypoglycemia in adults and pediatrics down to 6 years of age. So we'll look at the efficacy and safety of this new drug and provide place of therapy recommendations as we go along. The next slide just is an overview of the currently available glucagon products. You can see there, Baqsimi is the nasal spray product. The next two products are they require reconstitution and are administered sub-Q, IM, or IV. And then the last two products require no reconstitution, but must be given sub-Q. As I said, we're going to update the literature since the last review, but the last review was done in February of 2020, in which at that time we did establish a new PDL class for glucagon therapies. So there wasn't a lot identified in the literature search, just a few safety updates, and then the new drug evaluation. Just as a reminder, the preferred products in this class are Baqsimi, Glucagen, and Glucagon. And then the non-preferred products are subject just to the general non-preferred PA criteria. So we'll look, the next slide here is just some safety warnings I'll go over briefly. These were for all glucagon products with some small variations. So in general, the main warning is for use in patients with pheochromocytoma and risk of blood pressure increases that can be substantial. So these are contraindications. Some products also have a warning for use in patients with insulinoma due to the risk of hypoglycemia. And lastly, glucagon that should not be used in patients with glucagonoma when used as a diagnostic aid due to the risk of hypoglycemia. So then moving on to the new drug review, dasiglucagon, brand name Zigalog, is a it works by increasing blood glucose concentrations by activating hepatic glucagon receptors, and this results in glycogen breakdown and glucose release from the liver. I already went over the indication as it is an anti-hypoglycemic agent. This product is available in a ready-to-use pre-filled syringe or auto injector, so it does not require reconstitution, and it can be stored at room temperature for up to 12 months. So if we look at the next slide, which goes over the efficacy, this dasiglucagon was evaluated in 3 phase 3 multi-center double-blind placebo-controlled trials. 2 of those trials also had an active control arm to them as well, but there were no formal statistical comparisons to glucagon. 2 of the trials, the first 2 there were done in adults, and then the Battolino et al. Trial was a pediatric trial. In the adult trials, these were patients around 30 to 40 years old, with majority of them being white. And in the pediatric trial, the mean age was around 12 to 15 years. So the primary outcome was the same for all 3 trials. It was the time to glucose recovery, and this was defined as an increase in 20 milligrams per deciliter from the time of the administration of the dasiglucagon. And so what was found there, as you can see, a consistent result in that the median time to recovery was 10 minutes for the dasiglucagon, compared anywhere to 30 to 40 minutes for placebo, and then around 10 to 12 minutes, again, to the glucagon, which wasn't a formal comparison, but just as a reference. And then the secondary outcome looked at patients, the percent of patients that achieved glucose recovery within 15 minutes. And what was found there is about 88 to 99% of those patients treated with dasiglucagon did achieve glucose recovery, and this correlated with the number needed to treat of 1 to 2. If we look at the next slide of trial limitations, these were pretty small trials. The drug was administered in a hospital setting, and an artificial hypoglycemia situation was induced, and then the dasiglucagon was administered by a professional, and only 1 dose was given. So again, limited exposure. As I had mentioned, there were a limited number of non-white participants, as well as those ages 65 and older, and also patients with comorbidities were also excluded. Additionally, it would have been nice to have statistical comparisons with active treatments. If you look at the clinical safety in general, fairly common adverse events that you'd see with a glucagon product, and they were similar between adults and pediatrics. So nausea, vomiting, headache, diarrhea, and injection site pain. There were no serious safety concerns reported, and there are a few drug interactions with dasiglucagon with warfarin, indomethacin, and beta blockers. So the recommendation for this class is that dasiglucagon remain non-preferred with no changes to the preferred drug list, and to evaluate costs in executive session.
Great, thank you, Kathy. Any questions for Kathy? Okay, we do have 2 people that have signed up for public comment. The first is Emily Smith, who is a PharmD with Zealand Pharma. Emily, are you able to unmute yourself? Let me try this again. How about now? Emily, are you able to unmute yourself?
Yes, I think so. Can you hear me?
Yep, I hear you loud and clear. Sorry, maybe I made somebody else co-host, but the floor is yours. So again, you are a PharmD with Zealand Pharma.
Yes, I am a PharmD. I'm a HEOR director with Zealand. Thank you so much. Kathy, you did a fabulous job reviewing some of the things that I was going to cover, so I'm actually going to just hone in on a few specific things that really do differentiate this product from the other first and second generation products that are on the market. First of all, Zegalogue does have the longest shelf life of all of the second generation products. It has a 3-year expiration date from the date of manufacturer and may be stored in the refrigerator for this duration. Once it's removed from the refrigerator, it may be stored at room temperature for up to 12 months. That's the first thing that really differentiates it from the others. The second is the speed to recovery. That 10 minutes recovery time is the shortest if you just compare straight across all the package inserts of second generation products. And because of this rapid recovery, there's a significantly less likelihood need for a second dose. All of these package inserts recommend if the patient hasn't had sufficient recovery after 15 minutes to administer a second dose. Zegalogue has the lowest likelihood of a need for that second dose, and also the lowest likelihood of a need for EMS transport to the hospital. There's greater chance of home recovery with Zegalogue. The other thing that's really important to call out is the adverse event profiles. You're absolutely correct that adverse events are similar with Zegalogue in terms of the nausea, vomiting, headache, and injection site pain that you see with the other injectable glucagon products, but do not include the upper respiratory adverse events seen with Baqsimi. Obviously, we're not a nasal spray. We also don't have the hypoglycemia adverse event that you see in the pediatric study subjects with Gvoke. We have done some budget impact modeling that demonstrates that in a population of 1 million hypothetical covered lives, with it, where you would expect an occurrence of about 12,000 severe hypoglycemic events per year, treatment with Zegalogue was estimated to provide a total cost savings of 62% compared to the first generation kits that require multiple steps for reconstitution. And this is based on the fact that those first generation kits have a 70% failure rate of successful full dose administration. We've all heard the adage, the most expensive drug is the one that doesn't get into the patient. And that's what you have with the first generations. So in conclusion, I would just re-emphasize that Zegalogue in our clinical trials demonstrated a mean time to plasma glucose recovery of 10 minutes, with 99% of adults and 95% of pediatrics rescued within 15 minutes. So I would respectfully request that Zegalogue be added to the preferred drug list with no prior authorization requirement for the Medicaid beneficiaries of Oregon. So thank you very much for the opportunity to speak.
Thank you very much. Any questions for Emily? All right, thank you, Emily. We also have Dr. Andrew Amon. I made you a co-host. Are you able to unmute yourself, Dr. Amon?
Yes, Amon.
Almond. All right,
Okay.
thank you. Briefly for the committee, you're a professor up at OHSU. You were invited or made aware of this opportunity by Zealand Pharma, but you don't receive any honoraria from the company. Is that what I understand?
Correct. Mm-hmm.
Okay. Anything else you want to share with the committee before we start? Your timer.
No, I'll just give a little background. So I'm an adult endocrinologist. I'm director of the Harold Schnitzer Diabetes Health Center at OHSU, where we serve about 7,000 individual active patients, both pediatric and adult. And I'm division head for the endocrinology, diabetes, and clinical nutrition division up at OHSU. Been in practice for 35 years.
Appreciate
Okay.
that. Any questions from the committee before you begin? Great. All right, the floor is yours.
Okay, I'll start by saying I think the significance of my presentation today is for people to know that I'm here partly as a physician scientist. Partly
You're
as
breaking up.
Okay, I don't. I think I have good connection. Can you hear me now? Hello?
I can hear you.
Yes, we can.
Okay. I'm sorry. I'm sort of presenting.
Yes, we can hear you.
Okay. I intended to present today as a clinician scientist, someone who has been a specialist in diabetes for a long time, but also as a patient advocate. The significance of my presentation and my effort to be here, considering that I've never done any studies with this product, I have never even met with any of the representatives to my knowledge, and I've never taken any honoraria for this or for any previous work. So, and probably to show you how important it is to me, I'm on vacation in Arizona. The reason. But I think it's very important for patient advocacy to realize that this is the whole concept of glucagon and a convenient form of glucagon is so important. As I said, I've been practicing for a long time. I still have a lot of patients. I would say that I've had at least 6 patients who have died from hypoglycemia acutely. I have many, many more patients who have had falls, fractures, been caught in car crashes, going the wrong way on freeways and so forth related to hypoglycemia. And I can tell you that probably what's most important for this group is the fact that I would say that every year I have multiple patients who have had severe hypoglycemic episodes who end up calling 911 or go to the emergency room. And the vast majority of those could have been prevented by an easily accessible, easily usable product. Most of our patients have this. It's a standard of care for them. The American Diabetes Association recommends everybody have a glucagon product. But once you teach them, with the family members who have to give it in an urgent situation, anything that complicates it makes it more difficult. So a readily available solution product helps a lot. I think in the case of this product, that one thing to think about is that EpiPens, this doesn't seem to be a problem. People use EpiPens when it's appropriate. And I think that that's the concept of a simple injector, for instance, even makes it one step better, though any simple method of taking off a cap and giving an injection helps a lot. I think that that's the main things. I'm not going to give the science. I think that that's been given, and I can tell you that all of these products work well. I think it's just a matter of using it to prevent severe outcomes and to reduce EMT visits and emergency room visits.
Appreciate you taking the time to share your thoughts, and I want to see if the committee had any questions for you. Okay, again, hearing none, thank you very much. Turn it back over to Kathy to recap the recommendation.
Okay, thank you.
You bet.
Sure. So the recommendation was just to maintain dasiglucagon as non-preferred and no changes to the PDL and evaluate costs in an executive session.
Questions for Kathy? Any comments or a motion?
Motion to approve.
Second.
Thank you, Kathy.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
All right, let's get through one more topic before we move over, and we'll take a quick break, but draw your attention to page 95 in the packet, proximal nocturnal hypoglycemia. Deanna, you always get the classes with the tongue twisters, so I'm going to turn it over to you so I don't butcher it anymore.
Thank you, Roger. We just reviewed 2 of the drugs that are used for paroxysmal nocturnal hemoglobinuria in April of this year. We could go to the next slide. So the purpose for this review was to see if there's any additional comparative evidence either for eculizumab or ravulizumab, and then also to discuss the evidence for a new agent, pegcetacoplan, which was recently approved by the FDA for treatment of adults with PNH. Just as a reminder, eculizumab is also approved for 3 additional indications. They're pretty much rare diseases. It's the atypical hemolytic uremic syndrome, generalized myasthenia gravis, and then also treatment of adults that have neuromyelitis optica spectrum disorder. And then ravulizumab has 2 FDA-approved indications. It's used for PNH as well as the hemolytic uremic syndrome. Just as a reminder, after the exec session in our P&T meeting in April, we designated ravulizumab as preferred and eculizumab as non-preferred. And I think the main reason for that had to do with the fact that ravulizumab doesn't have to be administered as frequently as eculizumab. If you could go to the next slide, please. So given the short period of time, there were no new head-to-head trials that have been published to evaluate the comparative safety of eculizumab with ravulizumab. However, the National Institute for Health and Care Excellence, or NICE, they did issue guidance in May for the use of ravulizumab for treating PNH, and basically is recommended as an option for treating PNH in adults that have hemolysis and clinical symptoms that suggest high disease activity, or if they've been using eculizumab and they're stable for at least 6 months, it's reasonable to consider transitioning to ravulizumab. Next slide, please. Ravulizumab was granted some additional indications in June of 2021 by the FDA, and now ravulizumab is approved in pediatric patients that are 1 month of age of older and weigh 5 kilograms or more. And it's got the dual indications for PNH or the atypical hemolytic uremic syndrome. All right, let's go on to the next slide. So with that, we'll move into the new drug review for pegcetacoplan, which the new drug evaluation begins on page 99 of the packet. So the FDA approved indication for this drug is for PNH, which is the topic for this class update. What makes pegcetacoplan unique is that it binds to complement protein C3. So it prevents both intravascular and extravascular hemolysis. If you look back at the mechanism for eculizumab and ravulizumab, those are C5 inhibitors. And so they only target the intravascular hemolysis. And that was one of the things they noticed in the studies, is that despite treatment with those agents, people still continued to have some hemolysis. The FDA approved dosing for pegcetacoplan is 1,080 milligrams by subcutaneous infusion twice a week via a commercially available pump. So this drug is unique, as the first two agents require intravenous infusion over 30 to 60 minutes, depending on which drug is being infused, and it needs to be administered by a healthcare provider, where pegcetacoplan, once the patient has been properly trained, they could do the sub-Q administration at home. Next slide, please. So the safety and efficacy of pegcetacoplan was evaluated in a 48-week prospective randomized multi-center open label active comparator trial. The table 4 on page 103 of the packet has more details about this Pegasus trial. There were also two phase 2 trials that I think the FDA reviewed as well. So patients that were enrolled in this trial had received treatment with eculizumab, but their hemoglobin levels still remained low despite treatment. This was a 3-part trial design, in that there was a 4-week run-in period in which patients received both pegcetacoplan and eculizumab, the current dose they were taking. The reason for the run-in was to avoid abruptly switching patients from eculizumab to pegcetacoplan. And then the 16-week randomized controlled period was next. And in that 16-week period, patients were randomized to receive either pegcetacoplan or eculizumab monotherapy. And then the trial finished up with a 32-week open label pegcetacoplan only period. So the primary outcome was to look at the change from baseline in hemoglobin at week 16. And when you look at the least square means difference, you see that pegcetacoplan improved hemoglobin by an average of 2.4 grams per deciliter, while eculizumab, the mean hemoglobin levels continued to drop by a mean value of 1.5. So this was statistically significant, and the superiority of pegcetacoplan over eculizumab was proven in this 16-week component of the trial. A secondary outcome was the transfusion avoidance. This was a non-inferiority assessment, and the non-inferiority margin was set at 20%. And they noticed in this assessment that 85% of the patients who received pegcetacoplan were transfusion-free at 16 weeks versus 15% of the eculizumab treated patients. Superiority was not shown. This just showed that pegcetacoplan was non-inferior to eculizumab. Next slide, please. So some of the trial limitations, of course, as I pointed out, all of the patients were not treatment naive. They had received some sort of eculizumab treatment prior to enrollment, and they still had a hemoglobin that was less than 10.5. So we can't extrapolate data from this trial to treatment naive adults. That said, there is a current study that's ongoing looking at the efficacy of pegcetacoplan in treatment naive adults. Also, I pointed out this was an open label trial design, probably because the way the drugs are administered and the dosing frequency is different. So it would be very difficult to do a double-blinded study design. However, having the open label trial design does introduce some risks for bias. And then there was a small subset of patients two who required dose adjustments of the pegcetacoplan because they weren't responding to therapy. So that may have indicated that they had more serious disease than the other patients. Next slide, please. So the adverse drug reactions, you'll notice that the pegcetacoplan, not surprisingly, had more injection site reactions compared to eculizumab because it was administered sub-Q. In terms of diarrhea, we saw more diarrhea with pegcetacoplan than we did with eculizumab, but there was less fatigue and headache with pegcetacoplan versus eculizumab. You will notice that both drugs, both pegcetacoplan and eculizumab, since they are both complement inhibitors, they do increase the risk of infections. In fact, much like the C5 complement inhibitors, pegcetacoplan as a C3 complement inhibitor carries a black box warning regarding the risk of infection, and patients need to be vaccinated before they receive any one of these drugs. Next slide, please. So the recommendations for this review are to revise the ravulizumab PA criteria to reflect the expanded indication for use in pediatric patients that are 1 month of age and 5 kilograms or more. And then we revised the dosing table that was accompanying the PA criteria to reflect the updated indications. We will, the proposal is to add pegcetacoplan to the biologic for rare diseases drug class on the preferred drug list, and then implement prior authorization criteria for pegcetacoplan, which is outlined in Appendix 4. If we could go to the next slide, I'll talk about the specific PA changes, which begin on page 110 of the packet. So the biggest changes to the ravulizumab and the eculizumab PA criteria was to strengthen the vaccinations that are required prior to starting this drug, making sure that those recommendations were consistent with the ACIP recommendations for vaccination in patients with complement deficiencies. And then you see there in question 5 that we revised the population that's approved to use ravulizumab to be patients that are at least 1 month of age or weighing at least weighing 5 kilograms. And then if we go to the next slide, This just shows you the update to table 1 that reflects the various dosing regimens that are recommended for ravulizumab, depending on how much the patient weighs. The next slide is the PA criteria for the pegcetacoplan, which begins on page 113. This PA criteria is very similar to the eculizumab and the ravulizumab, and that we're making sure that it's being used for an appropriate diagnosis that's funded by OHP, and that the patient has met the safety guidance outlined in the black box warning regarding immunization. Next slide, please. And then we also added renewal criteria for pegcetacoplan to make sure that they are having benefit from the treatment. And again, the treatment benefit will vary whether it's hemoglobin stabilization, decreased transfusion, or symptom improvement. So before we move into public comment, are there any questions for me based on the information I presented?
This Bill Orger, I've got a comment. This study has considerable selection bias. The selection bias is they only chose people who had a low hemoglobin, less than 10.5, on eculizumab. So a patient who was successfully treated with eculizumab and had a higher hemoglobin was excluded from the study. So this is weighted to pick people that did not do well on the alternative treatment. So I am very skeptical of this study. It's extreme selection bias. Just pick the ones that it didn't work and then test those. And that would be a whole lot different than testing all comers.
I completely agree. As always, you have excellent commentary on the study design.
Thanks, Bill.
With
Other
that,
questions for Deanna? What was that, Bill?
I don't think this study proves non-inferiority because of the selection bias.
And that's the reasons that we thought we would wait till executive session to decide if this drug should be preferred or non-preferred on the PDL, because I really don't think the clinical evidence, it shows the drug is effective, but it doesn't really give you comparative evidence in terms of comparing it to eculizumab or even ravulizumab.
Agreed, thank you.
Other questions or comments? All right, we do have public comment. We have Jamie Tobit, a PharmD with Apellis Pharmaceuticals. Jamie, I attempted to make you a co-host. Are you able to unmute yourself?
I think I may be. Can you hear me?
You bet. I hear you loud and clear.
Very good. All right. Let's see. I had some prepared comments, but there was an excellent overview. Maybe I could have just addressed a few of the questions that kind of came up in the discussion. But I'm Jamie Tobit. I'm with Medical Affairs with Apellis Pharmaceuticals. A couple of comments I'd like to just mention. For one is the discussion about the selection bias. The patients that were on eculizumab were on stable, constant doses. They were not considered failure because they were still taking it. We had several of those patients that were not needing transfusions prior to enrollment. And at the time that they basically, that was their normal. There were no other alternatives for them to be treated with. We have done a matching adjusted indirect comparison with our patients to the patients in eculizumab, as well as the eculizumab study with ravulizumab, to match characteristics and continue to show a better result. But I realize we won't have time to get into that as much. The other things I wanted to mention, a couple of just FYI, that we do provide a service to the patients for the training, including as well as the infusion pump. All of that is provided at no cost to the patient, and Apellis is providing both the training and the pumps that are necessary. A couple other points. I'm sorry, I'm a little bit out of order, but we mentioned the two other studies that were part of the label. Those were, they were included in the FDA label. Those were in naive populations. So there was a small studies in naive populations, and that was one of the reasons why we got the indication for naive populations, as well as we have are completing our, as you mentioned, our phase 3 study for naive patients that was not completed in time for the FDA label. However, with top line information coming out, we're showing that nearly 86% of the patients on pegcetacoplan versus the naive patients on standard of care showed stabilization hemoglobin, a substantial drop in their LDH, with 91% of them being transfusion free versus only 22% in the standard of care, and a substantial bump in their hemoglobin up into the lower limits of normal. We will be presenting more of the data on this naive population at the ASH meeting, which is coming up in a few weeks. We have also included, our vaccination requirements are accurately mentioned, as well as they are required for both the ravulizumab and eculizumab. And we have continued long-term data from the Pegasus trial, which showed that the patients then, when they went from their eculizumab back and we put them onto pegcetacoplan, we again saw a substantial improvement in their hemoglobin after being randomized down. I know that it's kind of a bit rambling. I hope that address a few of the comments, and happy to take any other questions.
Great, thank you, Jamie. Any questions for Jamie? All right. Appreciate your time. So the recommendations, and any more questions for Deanna? So again, the recommendations are to revise the ravulizumab PA criteria to reflect the expanded indication, revise the dosing table, add pegcetacoplan to the biologics for rare disease drug class. We're going to review it for PDL placement exec session, and implement the PA criteria to limit use to FDA-approved indications. No questions. Do we have a motion to approve those recommendations or amend them?
Motion to approve.
Second.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
All right. I think we're at the place on the agenda. We're straight up at 3 o'clock. Let's take a 10-minute break, and then we'll reconvene to continue with the rest of the agenda, and then go into executive session. Does that work for the committee?
Sounds
all right,
good.
I'm going to put up
Yeah.
the timer.
Sounds good, Roger.
You bet. I'll put up the timer, and we'll see you in 10 minutes. Okay, we're just about to get started again. Stop my magic timer. And I did want to acknowledge right towards the end of the last presentation, before we went into break, one of the PNT committee members, Karen Michelson, was able to join us. Karen, do you want to take an opportunity quickly to introduce yourself?
Sure, I'm Karen Michelson. I'm the Director of Pharmacy for the Coquille Indian Tribe in Coos Bay, Oregon.
Great, glad you were able to join. You bet. We'll continue on, directing your attention, if you're following along in the packet, to page 115 for the GNRH modifier class update with an NDE. And it's still in Deanna Moretz's hands. So Deanna, we'll turn it over to you.
Thank you, Roger. All right, so basically we're going to be talking about endometriosis and uterine fibroid treatments. We last talked about endometriosis treatments at the March 2019 meeting. We've never talked about uterine fibroid treatment, and that's because we really haven't had any FDA-approved treatments for managing fibroids until recently. Next slide, please. So the purpose of this review was to see if we had any new comparative evidence for the safety and efficacy of pharmacologic agents used to manage moderate to severe pain that's associated with endometriosis. And then also we wanted to look at the evidence that was presented to the FDA for the improvement of relugolix combination therapy, which was FDA approved for management of heavy menstrual bleeding associated with uterine fibroids in premenopausal populations. Next slide, please. So there was no new evidence focused on the safety and efficacy of agents used to manage pain associated with endometriosis since our last review in 2019. Before we talk about the new agent, I wanted to just give a little background about what drugs are available for helping to manage heavy menstrual bleeding associated with uterine fibroids. So starting in 2017, AHRQ put together a systematic review that showed there was moderate quality evidence that showed that the gonadotropin releasing hormone agonists, leuprolide and goserelin, and the progestin receptor agent mifeprostone reduced fibroid size and improved fibroid-related symptoms, including bleeding and quality of life. 2018 Cochrane review, there was a focus on using tranexamic acid to minimize the heavy menstrual bleeding that is seen in some women. This did not look at bleeding associated with fibroids. It was just looking at tranexamic acid used to reduce heavy menstrual bleeding. And they did show that compared to placebo, tranexamic acid reduced the bleeding by about 50 mLs per cycle. And that was moderate quality evidence. And then finally in 2020, there was a Cochrane review that looked at using progestin or the progestin releasing IUDs in treating fibroids. And unfortunately, there was only low quality evidence available to evaluate the effectiveness of levonorgestrel releasing IUDs to reduce abnormal uterine bleeding associated with fibroids when compared to oral contraceptives. And also there was insufficient evidence when they tried to compare oral progesterones with goserelin for fibroid treatment. If we could go to the next slide. NICE put together some guidance in 2018, and they actually recommended off-label use of levonorgestrel IUD as first-line therapy for women that had fibroids that were less than 3 centimeters, and if it wasn't causing distortion of the uterine cavity. If the woman did not want to use the IUD or wasn't a suitable candidate, then there was 3 other agents that NICE recommended: tranexamic acid, combined hormonal contraception, or cyclic oral progesterones. And then finally, if the woman wasn't a good candidate or the pharmacologic treatments weren't effective, surgery was the next option. I did want to point out that ACOG, the Association of Obstetrics and Gynecology, they put out some guidance as well in 2021. Their guidance was primarily based on expert consensus. It wasn't based on a systematic review. However, their recommendations were very similar to NICE, and basically said we don't have a lot of good evidence to provide guidance on first-line medical therapy, and that treatment should be guided by the individual patient's symptoms and treatment goals, and that the medical management should be tailored to the patient's age, symptoms, desire to maintain fertility, and access to treatment. Next slide, please. So we do have 2 new formulations that have been FDA approved since our last review. And the first is this extended release formulation of leuprolide, which received FDA approval for treatment of pediatric patients 2 years of age and older with central precocious puberty. And then in 2020, a combination product of elagolix with estradiol and norethindrine was the first drug that received FDA approval for management of heavy menstrual bleeding associated with uterine fibroids in premenopausal women. You remember, elagolix was the drug that we reviewed for endometriosis in 2019. All right, next slide, please. So our new drug evaluation for relugolix begins on page 126. Relugolix was initially approved under the brand name Orgovyx for treatment of adults with advanced prostate cancer. In May of 2021, the FDA granted approval for this oral fixed dose combination of relugolix with estradiol and norethindrone for management of heavy menstrual bleeding associated with uterine fibroids. So relugolix, like elagolix, inhibits the endogenous gonadotropin releasing hormone, which eventually prevents release of luteinizing hormone and follicle stimulating hormone, which reduces the amount of endometrium that is generated in the body and then subsequently eliminated during menses. The reason estradiol and norethindrone are included in this combination therapy is to help ameliorate the side effects that are seen with relugolix, and particularly the effects that are seen by reducing estrogen, such as vasomotor symptoms and reductions in bone mineral density. And then the norethindrone is added back to prevent endometrial hyperplasia and malignancies that are associated with unopposed estrogen use. The difference between relugolix and elagolix is that relugolix combination therapy only has to be given once a day, where the elagolix combination therapy has to be given twice a day. All right, next slide. We were getting there a minute ago. So additional details about these two trials are presented in table 5 on page 129. So this was a double-blind, placebo-controlled, 2 different trials with about 400 patients each. Patients were randomized 1:1:1. So either they received once a day placebo or the relugolix combination therapy, which contained 40 milligrams of relugolix, 1 milligram of estradiol, and 0.5 milligrams of norethindrone for 24 weeks. But there was an additional arm that was delayed relugolix combination therapies. So in other words, they gave relugolix monotherapy for 12 weeks, and then they added back the estradiol and norethindrone along with relugolix for the last 12 weeks. And the purpose for that was to assess the safety impact on bone mineral density and the vasomotor symptoms. But for purposes of this slide, I just showed you the results from the placebo versus combination therapy over 24 weeks. So the primary outcome was the number of responders that had reduced volume of menstrual blood loss that was less than 80 mLs and that was greater than 50% reduction from baseline over the last 35 days of treatment. Interestingly enough, the way they determined blood loss was by using the alkaline hematin test, which involves chemically measuring the blood content of used sanitary products. This is considered the gold standard for determination of menstrual blood loss. And it has been used to diagnose heavy menstrual bleeding, and it's also been used as the primary endpoint in trials that evaluated heavy menstrual bleeding with the levonorgestrel IUD, with oral contraceptives, and leuprolide. So looking here, you can see that compared to placebo, the relugolix combination therapy, that's a tongue twister for sure, was definitely superior to placebo, and that there was a significant difference in the percent of people that responded to therapy with a number needed to treat of 2. Next slide, please. So the trial limitations were that patients that were enrolled in this had to pass initial screening, and the criteria for heavy menstrual bleeding was defined as 160 mLs of blood loss per 1 cycle or 80 mLs of blood loss for 2 cycles. just to compare normal blood loss is defined as 30 to 40 mLs per cycle. And then the diagnosis of fibroids had to be confirmed by ultrasound. So there may have been other patients that could have qualified for the trial, but because of the strict enrollment criteria, they were not included in the trial. In addition, the duration of the trial was only for 6 months, so we need more information regarding the long-term risks and benefits of relulogix therapy. And finally, we don't have any head-to-head comparisons for other drugs, for example, elagolix or leuprolide, in terms of the impact on reducing the volume of menstrual blood loss. Next slide, please. In terms of clinical safety, the adverse effects that were observed were the ones that you would see with estrogen reduction, hot flush or night sweats. There was some hypertension that was observed, and there was some abnormal uterine bleeding, as well as hair loss and decreased libido. Next slide, please. Back to the clinical safety. I wanted to point out that because this combination therapy contains estrogen and progestin, there is a black box warning regarding the risk of thromboembolic disorders. And this combination therapy is contraindicated in patients that have a history of thrombosis, or in women who are at increased risk for these events, including females over 35 years of age who smoke, or if they have uncontrolled hypertension. In addition, much like elagolix, this drug therapy should be limited to 24 months because of the risk of bone loss, which is not reversible, and the drug is contraindicated in patients with known osteoporosis. Next slide, please. So the recommendations are to, and thank you, Dr. Origer, he really helped with revising the PA criteria. Initially, we had all the GnRH modifiers in one set of PA criteria, and that's what had evolved at our 2019 meeting when we first evaluated elagolix. But Dr. Origer really thought we should probably separate it into two separate sets of PA criteria. So that's what we did. So we have one set for the GnRH antagonists, which includes this new relugolix combination therapy, as well as elagolix and the combination therapy. And that's separate from the GnRH agonist, for example, leuprolide, and we'll review comparative costs in the exec session. So let's go through the PA criteria. They start on page 138. And I'll start with the GnRH agonist first. So basically, we want to restrict the pediatric use to medical appropriate conditions that are funded under OHP. So all of the GnRH agonists that are prescribed for pediatric patients less than 18 have to be evaluated, as well as the non-preferred products. So basically, this is going back to PA criteria that we had before the March 2019 meeting. So basically, we're assessing, is it being prescribed by a pediatric endocrinologist if it's being used for either precocious puberty or gender dysphoria. And then if we go to the next page, if the leuprolide or the other agents are being approved for treatment of breast or prostate cancer, we will approve it. The next, if the leuprolide is being requested for management of preoperative anemia associated with uterine fibroids, we'll approve it for 3 months. That's the longest duration of therapy that leuprolide is recommended for treatment of anemia associated with sustained blood loss. And then question 10 goes into, is this being used for endometriosis? And if it is, we want them to step through the preferred first-line endometriosis therapy options, including combined hormonal contraceptives or progestins. And then we added some detail about the route that they would get the progestin, or if they have documented intolerance to any of those agents. And on the next page is the GnRH antagonists. So once again, we had this PA criteria in place just for the elagolix when it was the modifier PA therapy. So I just pulled this out. So like I said, we've got the 3 different agents, the elagolix monotherapy or the combination therapy with either elagolix or relugolix. If we could go to the next page. So again, we're assessing if the patient is pregnant or trying to conceive, the drug is contraindicated. If it's being requested for endometriosis, very similar to the leuprolide, we want them to try the first line options, the hormonal therapies, because those do not require PA. And if they are using the elagolix monotherapy for endometriosis, we also want to do an assessment about any possible drug interactions. Both of these drugs are eliminated through hepatic enzymes that impact drug metabolism. So if we go to the next slide, please. So this is just the assessment. The other thing with elagolix is you have to make sure that they have the dose has to be adjusted if they have impaired hepatic function. So the PA criteria address that. And then number 11 gets into, this is the new part where we were looking at if they were using it for the uterine fibroids. And then the first line step therapy, the options that we want them to step through, at least one of them, that's basically based on the NICE guidance and those systematic reviews that I presented to you earlier. So we want the person that is wanting to get this treatment for uterine fibroids to try either the levonorgestrel releasing IUD or combined hormonal contraceptives or cyclic progestins or tranexamic acid, or have a documented intolerance to that. And then finally, we want to make sure we assess the risk of osteoporosis before we approve the therapy. The next slide talks about the renewal criteria. But like I mentioned earlier, both of these drugs are limited to 24 months. So after the initial 6-month approval, if therapy is continued and they're showing an improvement, we would approve it for up to 18 months to make it a little bit easier for our PA reviewers so they don't have to keep reviewing this. All right, I know I went through this rather quickly. Are there any questions for me based on the information I presented?
I've got some comments.
Okay.
You know, medical treatment for this is not new. FDA indications for treatment is new. Oral contraceptives have been used for this since they were first introduced 50 years ago. And the studies are population studies, which were pretty good at the time, but not up to our snuff right now. And the first thing that was noticed is women who'd been on oral contraceptives for a lot of years had a much lower incidence of having fibroids than women who didn't take oral contraception. That was a population study. So then there were some population studies saying, what does it do for treatment? And these weren't controlled double blind. And right now, nobody's going to do controlled double blind studies. So there are some treatments, they're off label, they're cheap. And the newer treatments have not been compared to the older treatments. And there are some gaps in the data. The other part of this is missing the larger part of symptoms of fibroids, and that is pain, bloating, discomfort, dyspareunia, a whole bunch of things that has to do with the volume of the lesion. And that isn't mentioned here at all. And if it's only blood loss, I think you're doing people a great disservice not to consider the other symptoms of fibroids. And there's no data to show that these reduce the pain or misery.
I completely agree, Bill.
And I'm a guy, and all my information.
I'm giving you the woman's seal of approval on your statement here. No, I completely agree with that. And while blood loss of 50 milliliters throughout a cycle, less would be awesome. It really doesn't get at, I think, the bigger concerns that people who suffer from these conditions have. And that's right. It's the pain, it's the bloating, it's the feeling miserable, it's all of those things. And if there's, if there is no data to say whether or not these make any difference in any of those things that, arguably would have a bigger impact on quality of life and things like that. So.
Other questions or comments?
I was wondering, this is Kathy, on the approval criteria number 12, it says, if they have an FDA labeled contraindication, do we want to specifically state thromboembolic or thrombotic event of some kind in there, since it's contraindicated, or just consider that a good enough statement?
I would be more general, because the FDA may update contraindications between the publishing of this document and the next review.
What do others think? We do have public comment. Oh, go ahead, Bill.
I'm okay with the FDA contraindications as just a general guideline. That's fine with me.
And is that sufficient, Lan, for your team? When we reference an FDA labeled contraindication, that you can apply that based upon what those are at the moment of adjudication?
Yes.
Perfect.
I'm okay with
Okay.
that. Okay.
Great question, Kathy. And yeah, thank you, Lan. Other questions, or we do have public comment?
Can you just clarify in point 12, why are they all ors?
Because it's any one of them instead of an and.
We're just requiring that they try one. They don't have to try them all, just one of them. Do you think it should be changed?
It depends on how restrictive that it's trying to be.
All the first line options are, they don't require PA. They're all preferred, so they go through. And I think there's variations. Some women may not be able to tolerate the hormones, so that's why they would go with tranexamic acid. And as Dr. Origer pointed out, all of these are off-label. And I should have been more succinct in stating that these two drugs are the only ones that are FDA approved for treatment of fibroids, but we do have a lot of evidence for off-label use of the other agents.
Other questions? We do have Maggie Ullman with AbbVie. Maggie, I made you a co-host. Are you able to unmute your line?
I think so. Can you hear me, Roger?
Loud and clear.
Fantastic. Thank you.
The floor is yours.
Okay, so hello, everyone. I'm Dr. Margaret Ullman from AbbVie Medical Affairs. So I want to thank you for the time to speak to you today about Orilissa and Orion. Both medications use elagolix, an oral GnRH receptor antagonist, to provide reversible suppression of estradiol and progesterone and to impact women's health. First approved was Orilissa. It provides elagolix in 2 oral doses, 150 milligrams taken once daily and 200 milligrams taken twice daily, to provide the patient and provider flexibility in the treatment of the pain associated with endometriosis. Orilissa has been studied in a large phase 3 endometriosis trial and was shown to provide a significant dose-dependent improvement in dysmenorrhea and in non-menstrual pelvic pain at 3 months that was maintained over 12 months of the trial. It was also shown to provide a significant improvement in pain during sexual intercourse with the 200 milligram twice daily dose, and this response was also maintained over 12 months. Adverse reactions to Orlissa are related to the reduction in estradiol. Most common adverse reactions were hot flush, headache, and nausea. Orlissa is contraindicated in women who are pregnant and in women who have severe hepatic impairment, and duration of use is limited due to concerns about adverse impact on bone mineral density. Second to be approved was Orion. It's an oral treatment specifically approved for heavy menstrual bleeding associated with uterine fibroids in premenopausal women. The recommended dose of Orion is elagolix 300 milligrams with estradiol and norethindrone acetate in 1 capsule each morning, and 1 capsule that contains 300 milligrams of elagolix only in the evening. The estradiol and norethindrone is included in the formulation to help mitigate elagolix hypoestrogenic effects at this higher dose. In the 2 phase 3 clinical trials, Orion significantly reduced heavy menstrual bleeding compared to placebo, and about 3/4 of women achieving monthly blood loss less than 80 milliliters, and at least a 50% reduction in monthly blood loss from baseline during the 6th month. Reductions in monthly blood loss were apparent at week 1 and month 1, and their response was maintained through month 12. Some of these women started blood loss of about 1,000 milliliters. The average was 240. Orion significantly reduced symptom severity scores and increased health-related quality of life total scores versus placebo in both studies. I want to close by respectfully requesting that Orlissa and Orion be preferred treatments for women depending on Oregon Medicaid. Thanks for your time and consideration, and I'd be happy to answer any questions you might have.
Thanks, Maggie. Any questions for Maggie? Okay, recommendations are back up on the screen. So to implement the new PA criteria, we'll break out the antagonists from the agonists, and then we're going to review costs in executive session.
I do have a question just about the category and the 2 medications or the 2. Well, what should we call it? The 2 medicines that have indications for fibroids. It's my understanding that all of the contraceptive products are paid for with a different federal match rate than the than other medicines that are covered under the plan. Is that still the case?
Yeah, so drugs that are considered or classified as family planning have a 90-10 federal match.
Right.
I think if they have indications that are outside of the family planning, then they would just be the straight FMAP based upon the person's, the member receiving the therapy.
Right. So the implications are that if we were to approve these 2 products that are specifically indicated for fibroids, and there was also any sort of off-label use, then there would be exposure for the state plan for a higher payment on something that might be matched differently through the FMAP.
Well, the PA criteria would limit it, so it's not off-label, is what you're just mentioning, but I don't know if that answers your question. There is a different federal matching rate.
Right. Yeah, because there is a different federal matching rate, then there's a higher state cost exposure for use of the products that have the specific indication versus use of the things that have been historically used.
Again, depending on the member, right? If it's an expansion member of the ACA, you might even get a high match as well. But generally, conceptually, yeah. If birth control is used, that would generally be thrown into the family planning bucket and has that higher match. But when you drill down and look at the diagnosis and it's not for that family planning, then it would be at the FMAP.
Yeah, and the FMAP rate right now for Oregon is not favorable.
Boy, I don't have it off the top of my head, but 65, 67.
Yeah. Yeah.
Generic oral contraceptions are not a big ticket item.
No.
The discount stores sell them for $10 a month.
Well, and if you get them from a family planning clinic, I mean, they're essentially a year's worth is included in your visit, so.
So again, the recommendation in front of you is to implement PA criteria.
Yes.
So it sounds like you're in favor of having PA criteria.
I am. Yes, I would make that motion.
Okay.
Yeah, I think Mark made a motion. Do we have a second?
Second.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
All right. Turn your attention to page 146 in the pack. We'll do a growth hormone class update and turn it over to Dave Engen.
All right, thank you, Roger. Yeah, today we'll be reviewing the growth hormone class, and then we'll review the safety and efficacy of one new agent within this class. Next slide, please. So first, a little background. HERC currently restricts use of growth hormone to funded diagnoses where there's medical evidence of effectiveness and safety. Some childhood treatments that I've listed here should only continue until adult height as determined by bone age is achieved. And OHP, it does cover growth hormone for some select adult conditions such as HIV associated with cachexia and short bowel syndrome. But adult human growth hormone deficiency is currently not a funded condition. Next slide, please. There was an update to FDA labeling for growth hormone products in the treatment of Prader-Willi patients who are obese or respiratory impaired. Basically, the products are contraindicated due to risk of sudden death. Next slide, please. Recently, the FDA approved Lonapeg somatropin, known as Skytrofa. It's a once-weekly form of somatropin. It's approved for treatment of pediatric patients greater than 1 year old who weigh 11.5 kilograms or more and exhibit growth failure due to inadequate secretion of endogenous growth hormone. The agent binds to growth hormone receptor, as you'd expect, to signal cell growth and stimulate other metabolic processes. Next slide. So approval, it was based on one phase 3 open label, active controlled parallel group non-inferiority study of 161 patients with GHD. The trial was a year long, mainly looked at annualized height velocity. Lonapeg somatropin was found to have statistically non-inferior results compared to once daily somatropin, with an absolute difference between the two of roughly 0.9 centimeters per year. Next slide. Thank you. There were some key limitations. One being this was an open label study, relatively small treatment difference between it and the comparator. There was extensive manufacturer funding and support, and really not a very diverse group was studied. So it's unclear if the results would apply to other subpopulations with different ages, gender, race, or ethnic backgrounds represented in Oregon Medicaid. As far as adverse effects, there's a fair amount of fever, viral infection, cough, nausea, and vomiting, as you see there with the relative percentages in the Lonapeg somatropin group compared to the genotropin or the somatropin. So based on the review, next slide, please. We made some minor updates to the existing PA criteria. The first was to address those being treated for PWS and have a comorbid obesity or respiratory issue. So we asked the question, and that way it can be adjudicated appropriately if they have PWS and any of these conditions. The next slide, please. And then we added a question in for Lonapeg somatropin, make sure that it's being prescribed according to approved labeling, as I discussed earlier. So our recommendations would be to maintain Lonapeg somatropin as non-preferred in the growth hormone PDL class, update prior authorization criteria for GH agents to include Lonapeg somatropin, and evaluate comparative costs executive session.
Thanks, Dave. Any questions for Dave? We don't have any public comments, so we'd entertain a motion.
Move to approve.
Second, this is Helm.
Those in favor?
Aye.
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 Opposed? Abstain? Thank you.
All right. Thank you. And for our final class, we will go to the biotherapy literature scan and PA update, page 168 if you're following in the packet, and turn it back over to Deanna.
Okay, thank you, Roger. I just wanted to point out when we do the slit scan for the biotherapy, in the orphan drug update, which was consent agenda, there were 2 drugs that we added to the orphan drug, Liv Marley and ByLV. Both of those are approved for conditions, rare conditions where people have itching that's associated with hepatic dysfunction. So they were not included as new drugs for this because we don't have the published studies yet. Next slide, please. So for this slit scan, I found 3 recently published systematic reviews and 2 new clinical guidelines. And really what spurred this slit scan were the safety alerts that the FDA provided for obeticholic acid. So let's go to the next slide. All the diseases I'm getting ready to discuss are relatively rare. So the first systematic review was a Cochrane review where they looked at evaluating pharmacologic interventions in patients that had intrahepatic cholestasis of pregnancy. This is very uncommon. Its incidence is less than 2% a year. The specific outcomes the Cochrane reviewers looked at were maternal itching and adverse fetal impact. The itching score was measured using a 100 millimeter visual analog scale, where it ranged from 0, no itch, and 100 means severe itching. One study indicated that a change of 30 millimeters on that scale would be considered clinically meaningful. And what they found when they looked at the evidence for ursodeoxycholic acid or ursodiol was a very small difference in itching, only a change of 7 points. So I'd say that was clinically insignificant. And the other thing they found that there was insufficient evidence to evaluate fetal distress and stillbirth. Next slide, please. So a 2019 meta-analysis looked at ursodiol and obeticholic acid together versus monotherapy of ursodiol in patients with primary biliary angiocolitis, which is the FDA-approved indication for both of these drugs. The co-primary endpoint was reduction in serum alk phos and normalization of serum bilirubin. They found no statistically significant difference between combination therapy or monotherapy, but there was some changes in liver function tests in reducing the serum ALT, AST, and GGT, but there was no significant difference between groups in reducing conjugated bilirubin or rates of adverse events. Next slide, please. And then the final systematic review was published this year, and they were looking at the safety and efficacy of obeticholic acid in 3 different diseases. They looked at NASH, as well as PBC, or primary biliary cholangiitis, as well as primary sclerosing cholangiitis. As I mentioned previously, ursodiol and obeticholic acid are only FDA approved for patients with PBC. There's no FDA approved treatment for NASH or PSC. So in the patients with NASH, they did notice that obeticholic acid improved fibrosis, but there was no improvement in steatosis. However, the higher 25 milligram dose resulted in higher treatment discontinuation rates and increased itching. So not only do we see itching with the hepatic dysfunction, but itching is associated with the use of these therapies as well. When they looked at patients with PBC, obeticholic acid treatment led to a better response in ALK phos reduction. And then in the PSC patients, there was only one trial. There was a phase 2 dose-finding trial that showed that obeticholic acid might be helpful in reducing ALK phos, but it was a very small trial, so we need more evidence to support the use in those patients. Next slide, please. NICE did develop some guidance for the use of obeticholic acid and primary biliary cholangiitis in 2017. And it's recommended as an option in patients that have started on ursodiol and maybe aren't responding adequately, or if they have an intolerance to ursodiol, the obeticholic acid monotherapy might be a reasonable option. The starting dose that NICE recommends is the same as what's recommended by the FDA here in the States, to start at 5 milligrams once a day. And after 3 months, the dose can be increased to 10 milligrams. And then after 12 months, the response to therapy should be assessed to make sure there's clinical benefit. Next slide, please. Then the British Society of Gastroenterology liver section and a UK BBC group also came up with some guidance for primary biliary cholangiitis, and that they recommend ursodiol as first-line therapy in patients with primary biliary cholangiitis. And that's a strong recommendation based on high-quality evidence. And then they recommended to add obeticholic acid if patients are not responding to ursodiol or if they have intolerance. And that was a strong recommendation based on low-quality evidence. Next slide, please. So the safety warnings on obeticholic acid were starting to emerge in 2017 when the FDA issued drug safety communication regarding the increased risk of hepatic injury and death when obeticholic acid was not dosed appropriately. At that time, patients that had impaired hepatic function, it was recommended to use obeticholic acid 5 milligrams just once a week. So in 2018, the manufacturer added a box warning regarding the risk of hepatic decompensation if patients were correctly dosed based on their hepatic function. This year, in May of 2021, the FDA had gotten a lot more reports regarding the risk of serious hepatic injury and associated mortality when obeticholic acid was used in these patients with advanced cirrhosis. So now the box warning is strengthened regarding the risk of fatal hepatic injury with obeticholic acid. Next slide, please. So the recommendation is not to make any changes to the PDL at this time, but to modify our PA criteria for obeticholic acid to include the recommended dosing parameters and safety precautions to avoid serious hepatic injury. The PA criteria begin on page 178, and they're outlined on the next slide. So the changes to the obeticholic acid PA criteria were to strengthen that if the patient has to only use it if they have no cirrhosis, or if it's compensated cirrhosis, but they don't have serious symptoms due to the cirrhosis. Then they would go to question 4 to see if they've tried and failed ursodiol and what has their response been. And then question 6 is to make sure the dosing is appropriate. And we added a new table, which is on the next slide, that outlines the appropriate dosing for obeticholic acid. So it's 5 milligrams a day, once a day for 3 months when therapy is started, and then to titrate up to 10 milligrams once a day. If patients have intolerable itching associated with the therapy, the dose can be adjusted to every other day. And then it's definitely contraindicated in patients that have child Pew class B or C, or patients with a decompensation event as listed on this slide. And then the last thing was on the next slide, we added specific criteria under the renewal criteria. We could go to the next slide. So just being more specific about what improvement would look like, trying to follow P&T recommendations that we be more specific in terms of how are we assessing improvement from therapy. So using the guidance of having a decreased ALK phos, as well as decrease greater than 15% from baseline, and normalized bilirubin. With that, I will open it up to questions.
Thanks, Deanna. Questions for Deanna? All right, again, recommendations, no changes based on the clinical evidence, and we're going to modify the obeticholic PS and PA criteria to include the recommended dosing parameters for safety and to evaluate the costs in executive session.
I just have a follow-up question as somebody who always likes patient-oriented outcomes. I just love a thought about what looks like largely biochemical outcomes that were considered, and in reviewing the literature, how much did these tie in directly with confidence in improving patient-oriented outcomes?
That's a great question, because I talked about primary biliary cholangitis in the background for the lit scan, which we don't usually include in our lit scans. But you're right, a lot of times the symptoms are fatigue, and it goes undetected until they do the biochemical assessment. So I don't know if a lot of times therapy is not implemented until they do the testing and determine, and they figure out what's going on. Why are they having their symptoms? So do you think we should add something to the PA criteria about patient-oriented outcomes? These are pretty rare diseases the drug is indicated for. When we go to exec session, you'll see we don't have a lot of utilization.
Kat, I've got a comment on the secondary endpoints. The difference in the liver function tests were minimal. The change in the AST was minus 6.6 points. The decrease in the ALT was 15 points. That's nothing.
Yeah, so I'm just struggling with, like, do they actually help? And then just reading the black box warnings, and then people are resulting in liver failure. Like, why are people having liver failure? And is it actually preventing people from developing decompensated cirrhosis or sepsis? Or I don't know. I just wonder about, how effective are these in actually improving outcomes for patients? I don't know how much it would change the PA criteria. It was more of a comment on the evidence. I don't know if we have the manufacturers here today, but I would love to understand their opinion on sort of intermediate outcomes versus patient-oriented outcomes and how confident they are that these relate to any clinical improvements.
Yeah, and we don't have anybody that signed up to provide public comment for this class.
But that's a great comment about looking at the bigger picture. I think I put in the lit scan how many people we have. I'm looking back to see. I know we only have one patient that's on cholic acid, and most of our use in the bile salts is for ursodiol, which doesn't have the safety limitations that we've seen with obeticholic acid. We have minimal utilization of obeticholic acid. No claims at all. So I don't know if that reassures you that these drugs aren't, obeticholic acid in particular is not really being used.
I will be more reassured when the evidence is based on making sure that the outcomes actually matter to people. So I feel like this is a comment that I probably will be have raised a lot and will continue to raise a lot, but I just always would look to, are we changing numerical values that don't actually impact people, or are we actually improving their risk of dying or having hospitalization? So.
Great questions.
Yeah.
Are you okay with the criteria that we've put in front of you?
Move to approve.
For now? Thanks, Bill.
We have a second.
I'll second. This is Mark.
All right, all those in favor?
Aye.
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 Opposed?
Aye.
Abstain? Thank you. And thanks, Kat. I think that that this idea of the bigger picture definitely will come up again.
And with that, the P&T Committee will now meet in executive session for the purpose of the consideration of information or records that are exempt from disclosure by law. Executive session is held pursuant to RS 1926602F and ORS 414-356-1 and 2. Which allows the committee to meet in executive session to review confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that's necessary for the committee to make final recommendations or to comply with the requirements of RS 414-353. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend the executive session. Representatives of the news media are specifically directed not to report on any of the deliberations during the executive session except to state the general nature of the session as previously announced. No decision may be made in executive session. At the end of the executive session, we will return to open session. With that, for the committee, we are going to take you to session. All right, the recording has restarted. So with that, thanks for everybody's patience who's remained waiting for us to rejoin you. We've finished reviewing the classes to which we refer that we are going to meet and look at confidential pricing in an executive session. We only have a few changes that are going to be recommended to the PDL. So I am going to recap all of those recommendations and have one final vote from the committee if that works for everybody. So with that, for the inhaled drugs for cystic fibrosis with a literature scan after executive session, I just want to make sure again, confirm, can you all hear me clearly?
Yes.
Perfect. Okay, for the inhaled drugs for CF after the lit scan, make tobramycin and sodium chloride nebulized solution preferred, make Kitabis PAC non-preferred, and make tobramycin nebulizer solution non-preferred. In the glucagon class update, after review and executive session, the recommendation is to make no changes to the PDL. For the PNH class update, the recommendation is to maintain pegcetacoplan as non-preferred on the PDL. For the GnRH modifier class, the recommendation is to maintain relugolix, estradiol, norethadrone as non-preferred on the PDL. For the growth hormone class, no changes are recommended to the PDL. And finally, for the biotherapy lit scan, no changes are recommended to the PDL. Any questions or comments from the committee? If not, we need a motion to approve.
Motion to approve.
Second.
All right, sorry, my dogs are barking. All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you, everybody.
Well, we know who's going to let the dogs out in a moment. Appreciate again everybody's work. Kathy, I just can't thank you enough. You're going to be greatly missed, but wish you all the happiness upon retirement.
Thank you
The
so
next
much.
the next PNT committee meeting is slated for February 3rd. I think we'll probably get something on the books for an reorientation with the committee members that are moving on. Russ and Mark, thank you for being willing to be reappointed for another 3-year term, or at least part of a term, until we can find other interested warriors. So thank you, everybody. And with that, stay safe.
Yeah,
Have a
thanks,
great
everybody.
holiday.
Happy
Happy
holidays.
holidays.
Thank you.
Bye, Kathy. Thank you.
Bye.
Thank you.
Bye,
Bye-bye.
Kathy.